Hello and welcome to this educational activity entitled Expert Video Viewpoints on Castration-Resistant Prostate Cancer, Care Across the Continuum. I am Emmanuel Antonarakis, Assistant Professor of Oncology at the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center, and I'm joined by Dr. Leonard Gomella, Chairman, Department of Urology, Associate Director of Clinical Affairs, Jefferson Kimmel Cancer Center at the Thomas Jefferson University, and Dr. A. Oliver Sartor, the Laborde Endowed Professor of Cancer Research at the Tulane University School of Medicine. We'll now begin section 3 and talk about some of the novel and emerging therapies which are in development for castration-resistant prostate cancer. And I'd like to ask Dr. Sartor just to summarize the current phase 3 studies looking at novel agents in this setting.
Gosh, that's actually a big question, and we don't really have the opportunity to discuss each in turn. I'm going to refer people to the table. I just want to highlight that there are a variety of immunotherapies that are now being tested. Ipilimumab, we have the Prospect VF Tricom, novel agent which bears looking into in a little more detail. We have dasatinib, we have new results with radium-223, a new provocative agent, cabozantinib. TAC-700 has gone into some trials. We hope to hear about the NDV-3100 pretty soon, and then a new one called tesquinimod. So a whole range of new agents are now in phase 3. And as we move forward, I think we'll have to pay attention to all of them, to be honest with you.
I'd first like to touch back upon abiraterone. We heard about the post-chemotherapy study. I'd like Dr. Gomella to talk about the pre-chemotherapy phase 3 trial with this agent.
The abiraterone trial, known as the Cougar 302 trial, has completed the accrual, and basically this looked at abiraterone and prednisone versus placebo and prednisone in a 1-to-1 randomization, and this is in the pre-chemotherapy space. So while 301, which led to the approval, was post-chemotherapy, this will study abiraterone before chemotherapy.
And I'd like to also talk about a novel agent that actually works a little bit differently from abiraterone. It's called MDV-3100. Dr. Sartor, can you tell us about this mechanism of action?
Sure. So this really binds to the androgen receptor. It's an anti-androgen, but it binds tighter than the older agents such as bicalutamide or flutamide. So this agent has no partial agonism, which some of the other agents have potentially been shown to have. And in addition, it also blocks the translocation of the androgen receptor into the nucleus after the binding of the AR. So what we have here is probably a better anti-androgen. Now, in the development process, at higher doses, there were found to be some seizures. So in the phase 3 trial design, they backed off and used a little lower dose, but one that is unequivocally active. And this has now shown some pretty remarkable results, actually, in both the pre-docetaxel and post-docetaxel setting. A lot of PSA responses, but really the question is it going to work in the phase 3? And the phase 3 trial design, as it turns out, one post-docetaxel is completed accrual, one pre-docetaxel is still accruing, and overall survival are going to be, of course, the ultimate test here.
So I'll just stop you right there and I'll ask Dr. Gomella just to go in a bit more detail. The AFFIRM study, which is the post-chemotherapy MDV-3100 trial, can you discuss that with us?
Yeah, the AFFIRM trial is in the post-chemotherapy setting with NDV-3100. The accrual of this is already complete, so we're anxiously awaiting the results. It was almost 1,200 patients, and it looked at NDV-3100 versus placebo in the post-chemotherapy setting.
And there's also a very similar trial actually in the pre-chemotherapy setting entitled PREVAIL. Can you talk about that as well?
Correct. That's a slightly larger trial of about 1,700 patients that's going to look at MDV-3100 versus placebo in the setting of the pre-chemotherapy. Much like the other agents, are all being moved up earlier in the course of treatment.
Yeah, and for me, this is a very exciting time. We have a lot of new hormonal agents. In the past, we thought we had sort of gone as far as we could with these agents, and now all of a sudden we have 3, 4, 5 new agents. I'd like to ask Dr. Sartor to just talk about some of these other agents which are currently in phase 1, phase 2, soon to be in phase 3, targeting the androgen axis.
Sure. Well, as it turns out, there's another agent called TAC-700. It's a CYP17 inhibitor, and it also showed very promising preliminary sort of phase 1, phase 2 results, and was jumped immediately into phase 3, again, post-docetaxel, pre-docetaxel. There's a new agent called TOG001, and it has a multiplicity of actions. It appears to have some CYP17 inhibition, but it may also alter the androgen receptor. It may actually lead to a little downregulation of the androgen receptor. So there's phase 2 studies there, not in phase 3 yet. And then a brand new one called ARN-509, and this is another androgen receptor antagonist, sort of like NDV-3100, but some of the folks think it might even be better, so it's now undergoing preliminary testing.
And I'll shift gears now, talk about some of the novel immunotherapies. We've already heard about Sipuleucel T. And there's an interesting phase 3 study which is just about to start. I'd like Dr. Gamello just to talk about this study with Sipuleucel T.
So what's happening is the immunotherapies are being moved up earlier in the course of disease. This phase 3 study will be primarily done in Europe, and it's going to look at patients with hormone-naive metastatic prostate cancer, and it's going to randomize them to androgen deprivation therapy alone, or an induction course of Sipuleucel T and androgen deprivation therapy together.
Thank you. And, you know, another agent that we've heard a lot about, ipilimumab, actually just FDA approved for another disease, metastatic melanoma, also being tested in prostate cancer. Can you describe the mechanism of action of ipilimumab?
Very interesting. What the ipilimumab does is takes the brake off the immune response. So the CTLA-4, which is a brake on the T-cell response, is taken off by the ipilimumab, allowing a more robust T-cell response and hopefully anti-tumor effect.
And there's been a number of interesting phase 1, phase 2 studies with this agent leading to the phase 3 trials. But Dr. Sartor, can you summarize the early phase studies with ipilimumab in prostate patients?
Ipilimumab has been tested in the phase 1 and phase 2 setting, and we know now that it's unequivocally active in metastatic melanoma. These trials in prostate cancer did not really have a specific antigen that was targeted. It was just taking the brakes off the immune system. But unequivocally, there have been responses. In fact, some responses have been very robust. They did trials both with radiation and without radiation. Using radiation may actually help to present the antigens, and the results were promising enough that this agent has moved into phase 3 now.
Yeah, and one of the things that kind of sticks in my mind is that this agent is different from the other immunotherapies like Sipuleucel T. It actually does produce some PSA responses. It actually does cause some tumor regressions. And this is something we didn't actually see with Sipuleucel T. We haven't seen with Prosvac or other agents. So to me, this is probably working in a slightly different mechanism. But as you said, there's been a lot of interest in developing this in the phase 3 setting, and there's actually 2 phase 3 studies, very similar designs. Could you talk about those studies with ipilimumab in the phase 3 setting?
Sure. Well, one of them is going to be in the post-chemo setting, and I talked earlier about the docetaxel being a pivot point, and this is a perfect example. So this post-docetaxel trial will be utilizing radiation, hopefully to perhaps help the antigen presentation, and then either using IPI or the placebo with an overall survival endpoint. In addition, there's going to be a pre-chemotherapy setting, and again, placebo will be used as the control group, and overall survival will be the primary objective.
I now want to talk about another immunotherapy agent, vaccine therapy, called Prosvac. Dr. Gamello, can you talk about how this agent works?
Prosvac is really exciting. Basically, it's going to rely on a injection into the patient to stimulate their immune system using essentially a fowlpox virus and a vaccinia virus. It's also combined with adjuvants that stimulate the immune system, and it's a very exciting way for the future to treat prostate cancer through direct injection and stimulating the patient's own immune system through these fowlpox and vaccinia virus vectors.
Yeah, and I first heard about this when the phase 2 trial was presented by Dr. Kantoff. Could you please summarize for us, Dr. Sartor, the phase 2 trial with Prosvac and what the results were?
Sure. So the Prosvac trial was conducted in the asymptomatic metastatic castrate-resistant space, and patients were either given an empty vector or they were given the Prosvac. And after progression, there was an opportunity to cross over and receive the active agent if initially you were in the placebo arm. The primary endpoint was actually progression, but as it turned out, they followed the patients for a long time, and survival was also obtained. And the interesting result was survival was positive in the randomized phase 2.
And I think this has actually led to a lot of excitement, and this drug has now moved into phase 3. And there's actually a huge study which is about to launch. Dr. Gamello, could you talk to us about the PROSPECT trial?
Yeah, the Prosvac VF trial, or the Prospect trial as it's known, is going to have 3 arms to it. One is going to use the Prosvac VF with a GM-CSF. The other is going to just use the Prosvac VF alone, and the last is going to be strictly the placebo vector injection.
We're expecting this study to launch in about November of 2011. And now I want to shift gears once again to talk about new bone-targeted agents. Traditionally, we've had, as we mentioned, zoledronic acid. We've also had a class of agents called the radiopharmaceuticals, and the agents in this class include strontium-89 as well as samarium-153. Now, those agents actually were emitting beta waves, so beta radiation, And now there's a new agent, radium-223, which is different from the classic agents, and it's an alpha emitter. It emits a shorter wavelength of energy. And now this agent, radium-223, has gone into phase 3 trials. And I'd like Dr. Sartor just to talk about the phase 3 pivotal trial with radium-223 and perhaps some of the early results.
Well, it's a very provocative agent. It's an alpha particle, and there's never been an approved alpha particle before. An alpha particle has got 2 protons, 2 neutrons. It's a big particle, carries a lot of energy. These beta particles are really sort of electron type size, so this is like 7,000 times bigger, and it has a huge amount more energy. So after a randomized phase 2 showed a survival benefit, and of course that's not definitive, you got to take it into phase 3, there was a series of additional trials, by the way, that showed some relief in symptomatic disease, but it went into the phase 3. And the phase 3 was called the Alsimca trial. It included over 900 patients. And it was done for metastatic patients who were symptomatic, and many, in fact, most of them had had prior docetaxel. And the randomization was either to a placebo or 6 doses of the radium-223, and the primary endpoint was overall survival. And the amazing sort of thing is that sort of recapitulating what happened with the abiraterone, the Data Monitoring Committee actually stopped the trial early at an interim endpoint, predetermined interim endpoint. But the overall survival was so positive that they felt like that they had to stop the trial and allow the patients on the placebo arm to receive the active drug. So this is going to be presented at the ESMO meeting in Europe for the first time in September of 2011. And then, of course, we anticipate regulatory submissions to follow relatively shortly thereafter.
Yeah, that sounds very exciting to me. And another agent which really caught my interest, which I heard about in ASCO 2011, is a new TKI, tyrosine kinase inhibitor called cabozantinib, or XL184. Can you talk to us a little bit about this agent and sort of where it's going and what results we've seen with it so far?
Sure. So again, a very provocative new agent. It really inhibits a new target in terms of metastatic castration-resistant prostate cancer. It hits 2 of the receptors fairly effectively. One of them is called the c-MET receptor, and c-MET is overexpressed in a number of patients with metastatic, particularly bone metastatic castration-resistant prostate cancer. And it also hits VEGFR2, our old friend VEGF, and this is the receptor type 2. And this interaction appears to be particularly effective in animal models. So going into the humans, it was rather amazing, actually, that we saw for the first time bone scan responses. So we've gotten accustomed to looking at bone scans and realizing they can get worse but not better. The preliminary results here show unequivocally that a substantial number of patients can actually have bone scan responses. In addition, there's other evidence of activity in the soft tissue. So this is an agent we're trying to learn a lot more about quickly, and it's in phase 2 right now. It hasn't gone to phase 3 yet.
Just summarizing with some key takeaway messages now. We have several novel androgen-directed therapies. Some of them actually affect androgen biosynthesis, like the Tokai compound, the TAC700 compound. Other agents are actually affecting the androgen receptor in a more potent fashion than bicalutamide. Some of these agents are MDV3100, ARN509, currently in phase 1/2 studies. We've also heard about some novel immunotherapies which are currently in phase 3 studies, ipilimumab, 2 large phase 3 studies, as well as Prostvac, a pivotal phase 3 study. It's going to be opening in November 2011. In addition, we've heard about a 5th drug that might be improving overall survival for patients with prostate cancer, radium-223. And once again, cabozantinib, or XL184, a novel TKI blocking c-MET and VEGFR2 with sort of marked effect on bone metastases, something also to look out for in the future. And this concludes section 3.